Thank you for joining today's webinar titled How Physicians Can Extract Value from Their Own Clinical and Claims Data Through Data Aggregation. Today, we have co-founder Daniel Frier speaking, along with our New York City managing partner, John Morrone, and Associate Arielle Miliambro. Today's webinar will be recorded and sent to you in a few days. And if you look at the bottom of Zoom, you'll see the Q&A option. Please submit all your questions through there, and we'll do our best to answer them at the end of the presentation. And if not, we will be sure to reach out to you via email. So with that, Dan Frier, you're up.
Hi, everybody. Thank you for attending this webinar, and hope you're having a good afternoon. I'm going to be talking about general types of data as well as data contracting. And Arielle is going to be speaking about HIPAA considerations, and John Morrone will be speaking about some regulatory considerations surrounding data. We have a disclaimer that we do with every webinar. The only thing I'll mention is this webinar does not consist of us providing legal advice to you. This is simply an information webinar. If you have any questions that require legal advice, you should consult legal counsel in advance of taking any action. So before I get into the thick of the presentation, I want to explain, what's happening out in the marketplace, not just in the area where our firm is, in the New York metropolitan area, but around the country. And that is that there are players out in the healthcare field that are realizing that data has tremendous financial value and has tremendous clinical value as well. From the perspective of physicians and medical practices, which is really the focus of this particular webinar, medical practices can only compete in this marketplace if they fully understand their data. And what I mean by that is there's claims data that the payers have, and then there's clinical data, which is typically in the medical record or EMR systems. And that data is vast, diverse, complex. And if I were a physician and I were trying to remain somewhat autonomous in this environment, or at least remain competitive with all the aggregation that's happening and the competition by hospitals and the competition by large insurance companies, which are now employing physicians, one of the first things I would want to do is to control my data, potentially create a data warehouse. And I'd want to understand that process. So that's what we're going to talk about a little bit today. If this were a live webinar, I'd ask you to answer these questions right now, but you can't. But the typical question I ask is, which of these stakeholders owns the patient data? Is it the patient? Is it the physician? Is it the health plan? Do hospitals own patient data? Do labs own patient data? What about a private equity owned management company that has access to patient data? Which of those stakeholders owns the patient data? But are we really even asking the right question? Is it really relevant who owns the data? The fact is, data is available for appropriate use by all of the parties in the spectrum of the patient care, whether it be the patient, whether it be the physician, whether it be the health plan, whether it be a hospital or an ancillary service like a lab. Each of those parties has the right to utilize that data in certain ways. And Arielle is going to get into a much deeper dive in terms of HIPAA, but data, depending on how it's used and how it's treated and whether PHI is stripped from it, personal health information, can be used and commercialized in different ways. The way that I think it makes sense to appreciate how data works is there's a concept in the law called riparian rights. And this is how we're relating to this cartoon in the upper left. Under the concept of riparian rights, if you have property along, let's say, a stream, body of water, like a stream, you have the right to go to that stream that's crossing through your property and take out a couple buckets of water, use it to bathe, use it for cooking, use it to drink. But you don't have the right to dam that stream up. or divert the stream so that you now have total access to it. As those water particles are going through your property, you have the right to a reasonable use and a limited use of that water. You cannot just use it as if it were your own property. When that water molecule then goes down to your neighbor's property, just like a piece of data going to the next participant in the patient spectrum, that water particle can be used by that individual or that party for what they want to use it for. Maybe they have some light industrial use they're going to use it for. And as long as it complies with the law, they can, but they can't unduly impair the rights of subsequent people that are downstream from them. That's sort of the way data works as well. And once you take that water in a bucket and you pull it out of the stream and you bring it into your house, that water is yours. If someone were to come into your house and take that bucket, it would be stealing. That water sort of magically became your water when you brought it in for reasonable use into your home. And that's similar to data as well. And you as physicians, as medical practices, you can utilize data and extract it for your own legitimate uses. And once you do that, it becomes you have rights to that data. So there's multiple types of data, and if for you to understand the role of data in your practice and how you can utilize it and how you can profit from it potentially in an appropriate way, you have to understand what it is. And there's different types. So there's this concept of raw data. There's structured data, there's unstructured, normalized, curated. So the concept of raw data is essentially the data as it currently exists in a medical practice's EMR system, in a medical practice management system. If it's claims data, it's data that exists in written form on a chart, if there's any written charts at issue. It's data that exists in the hospital related to a procedure that was performed on a practice's patient. All that is the raw data. And raw data is really very cumbersome to utilize, generally requires a human set of eyes to look over it and try to make connections to it. And that's fine with 1 or 2 patients, but if you're talking about thousands of patients, it's essentially impossible to make any use of that raw data. Raw data is confounded also by the idea that it's entered by different people who have different protocols for entering data. You may have one physician who enters a description one way and another physician enters a description another way. And if you're trying to search that data in its raw form, it's impossible to be able to get meaningful results from that if you don't normalize it in some way. Structured and unstructured data. Structured and unstructured data structured data is essentially any data that's contained in the electronic health record in the form of a field, typically. So fields that are entered either manually or automatically are structured data. Unstructured data would be anything else in the medical record, such as scanned in reports, lab reports, op reports, scanned in notes, anything that's not in the fields. As you can imagine, extracting information from structured fields is generally easier than extracting information from, let's say, a scanned PDF, which again, it would be very difficult to use that unstructured data in a meaningful way. And then there's this concept, I mentioned it earlier, normalized data, which is essentially data that has been formulated by some either computer software, by sometimes just raw time spent by individuals, taking 2 pieces, for example, of disparate information, such as if you're describing someone's cancer stage, one physician might enter it as stage 3 with the letter 3 and so the number 3, and someone might describe it as stage 3 spelled out THREE. So normalizing data is important, and so what happens is both of them would be structured in the same way so that you can search the information, and you can come up with meaningful results from that search. And then the concept, so I'll go something that says, we talked about raw data, normalized versus curated data. This slide on the right, apples to oranges, you're trying to make apples to apples, essentially, what you're doing when you're normalizing the data. And curated data is essentially what happens when you have normalized data and you then have some third party typically, or it could be yourself, that then does a study on that data, that decides to run a program to determine, okay, how many of our patients, have this particular disease state and are being treated by this particular medication. How many of those people have been on that medication for more than 3 years? And how many of those patients, have continue to have certain side effects? You can, running a specific study on data that's been aggregated and normalized is typically how the term curated is used. So it's important to understand the verbiage. So the next thing I want to talk about briefly is data contracts. There are two types of data contracts. There are overt data contracts. An overt data contract is one in which you are knowingly selling or licensing your data to a third party. And typically the entire contract is focused on that, on allowing a third party to utilize your data in some capacity. And we'll talk about the details of that in a moment. Covert contracts are very common, and one of the things I want to caution you about during this webinar, a covert contract is a contract in which data is transferred to a third party, perhaps for some ancillary purpose, and often and data rights are sold or handed over without the knowledge of the medical practice. So, for example, if you sign an EMR contract with the EMR provider, and there's a provision in that agreement that says the EMR provider has the right to de-identify and then use that data any way it wants, you've just handed over the rights to your data for free for them to go out and maybe sell that data to a pharmaceutical company for maybe millions of dollars. You've just handed them that right to do that. And if you're going to do that, you should know you're doing it. That's what I wanted to make sure everyone understood on this webinar, which is don't allow your data to be transferred or any rights to be transferred without your complete knowledge that it's happening, and maybe an opportunity to negotiate something or limit that ability as well. So let's talk about some just important contract terms, whether it's in a covert contract or an overt contract. The first thing is defining data usage rights. There's two basic concepts. There's ownership of the data, which is a concept that honestly, as we kind of described earlier, is really a difficult thing to get your hands around. Who really owns data? The more common term that's used when we're talking about data is the concept of licensing data. A license is almost like a lease, but it's what you're doing is you're allowing a third party to utilize the data either without restrictions or with restrictions, and you're allowing them to use it either exclusively or non-exclusively. We'll get into that shortly, but the concept of licensing is more common, where you're giving a third party the right to utilize the data. And frankly, if you think about it, owning data is not really like owning a piece of property. Data is something that you don't need for a long period of time. A piece of data today becomes obsolete rather quickly. Several years from now, it's no longer even valuable necessarily. So this concept of licensing data is going to be something that will come into these contracts. And then the question of what the data can be used for is another question that needs to be answered very, very carefully in the agreements. This is often the subject of significant negotiations. The third party has licensed its rights. It has licensing rights to use data. And the question is, what can it use that data for? Can it use it for any reason at all, any purpose at all, or can it only use that for certain reasons? Keep in mind that if you are looking to, for example, commercialize your data with, let's say, the pharmaceutical industry, the more parties that have rights to your data, arguably, the less valuable it is to any one party, including yourself, because it's now sort of the value has been diluted. The pharmaceutical industry doesn't have to look to you for the source of that information. They can look to the other parties that now have rights to that data. And another important aspect to defining data usage is what happens to data when the contract ends. Does the third party have to destroy it? Do they have perpetual usage of it forever? These are things that need to be negotiated as part of the agreement. Exclusivity, which I mentioned. The concept of exclusivity with data is simply once the data rights are sold or licensed by the practice, can the practice then sell the same license or issue a license for the same data to another party? And obviously, from the practice perspective, it would like the data rights to be non-exclusive, so that it can sell. I'm using that term loosely. Sell the data to other parties, and it doesn't have to limit its data usage. And in other instances, however, depending on what's being paid for that data, a third party may say, "Look, we're essentially paying a significant amount for the data. We want to know that it will not be the value will not be diluted in the future if you were to sell it to other folks." Term and termination. These are common issues in various contracts, and the question is when I look at these strictly data contract, one of the first questions is, how long is the duration of this agreement, right? We're talking about an extremely cutting edge part of the law and a cutting edge part of medicine, the use of data. And so giving up data rights to a third party, selling data today for a price that works today, may quickly become an obsolete concept, in 6 months or a year. So when I'm working with medical practices, I prefer a shorter term. Typically, it's to the practice's advantage to be able to renegotiate sooner rather than be stuck in a long-term, 3 to 5 year contract. The termination provisions, I generally like such a scenario where the practice can terminate without cause on a certain amount of notice. And sometimes data companies will not. There are companies that will buy data from medical practices, and if they do that, they often want to lock the practice into a long-term contract because they may be entering into contracts with third parties to buy that data, and they need to be able to assure the third party that they have access for some relevant period of time. So it may be something you have to give in on. I'll just one note I'll make here, just so that I don't forget to mention it to everybody. I talked very early on about this concept of a data warehouse. The concept of a data warehouse is something that's relatively new in healthcare, for medical practices, but it generally involves the medical practice, especially a large medical practice with numerous providers. Aggregating the data as I described in a server, utilizing maybe a third party for this purpose, normalizing the data and having it ready and available at any given moment with up-to-date data, so that it can enter into these third-party data contracts. It's very hard to enter into a data contract if you just have your data in raw form, sitting in your EMR, sitting in your records, sitting in your claims history. It's very hard for you to monetize or commercialize that data, or even use it for your own patient care. Another very common provision in these agreements is indemnification. Indemnification. Almost every contract has some indemnification provision in it. And what does it mean? Well, indemnification, if you ever see this in any contract, what it essentially means is that one party is made a decision that it either wants to accept or push risk of some act or omission. It wants to either accept that risk or push that risk to a third party. And if it pushes the risk to a third party, that third party will cover the losses of the other party that are typically caused by an act or omission of that second party that's taking the risk. So in other words, you are entering into a data contract. A third party breaches its obligations under HIPAA and discloses PHI inappropriately, and you've now engaged indirectly in a HIPAA violation. It's very common for the body of the agreement or the business associate agreement, which Arielle will talk about, to provide that the third party that has created the breach indemnify the practice under that circumstance. And many times you'll see that the third party wants indemnification as well. Without getting into a huge discussion of indemnification, which probably could take 30 minutes in and of itself, I'll say that you should not take indemnification provisions lightly. You shouldn't just sign them thinking, oh, this is just legalese. When you agree to indemnify a third party, what you're doing is you're giving them the contractual right to basically, if they get sued, to basically say, this is your problem now, not ours. And you now effectively, for all intents and purposes, become the defendant in that underlying case. So just be cautious about that. So let's talk about consideration. The legal term consideration means what are you receiving? What value are you receiving in exchange for something? In this case, data. So there really are there's really only a couple different things that you're getting when you enter into a data contract. You can get money. You can actually charge for data use, data licensing to a third party that then utilizes that data. And pharmaceutical companies are paying huge amounts of money for data because they are starving for that information to verify the effectiveness of their drugs, or to find out, okay, who's using our medications, who's using our drugs, what is the typical demographic of the patient that uses our drug, what's the demographic of the physician who is prescribing the drug within a single practice, that has several physicians and several thousand patients. There's an immense amount of data, statistically relevant sample of data within that practice that the pharmaceutical, the DME industry can utilize to make financial decisions or clinical decisions. The second type of consideration that a medical practice can get from the data is if you have a data warehouse and you enter into a contract with a company that curates that data. So typically there are these third-party entities that will curate the data, and they find pharmaceutical companies that are doing studies, and what they'll do is this third party will curate the data for the pharmaceutical company, get paid by the pharmaceutical company, and then pay the practice a portion of that in exchange for the use of the data. So these curation companies are sort of middlemen, but they're performing a function, which is they're taking this data from the data warehouse I described, and they are customizing it or curating it for the purposes of a particular study that's being done by a pharmaceutical company, let's say. And so sometimes what they're doing from a curation standpoint is not only useful to the pharmaceutical company, but it also can be useful to the practice. It can enable the practice to understand its own information, its own clinical care in a way that it didn't understand before, and in a way that the third-party payers don't understand. So the value of this getting this curated data back to the practice can be just as valuable or more valuable than receiving money for the data if, for example, that practice is engaged in value-based care. And in that value-based program, let's say you have a practice that's working under a bundled payment program or a shared savings program. A bundled payment program is a good example, because if you're taking on financial risk as a practice through a bundled payment plan, you're receiving a lump sum for a particular type of treatment or a particular disease state. You really can't do that on a grand scale unless you understand, what your risks are, what risk you're undertaking, and you need to understand your data to do that. You need to understand, okay, this provider is providing the same service at a 20% higher cost than this provider. Why is that happening? Why is this provider? What is it about their care that's making their treatment more expensive, and how can we change that? You can't do that with the information, the claims data that the insurance companies happen to be sharing with you. It's too limited. You can't really trust that data also, because it's coming from a third party that doesn't have a vested interest in giving you proper information necessarily. So taking control of your own data, utilizing these third-party curation companies to give back that information to you in a usable way is very, very valuable. With that, I'm going to hand over the slides to, actually, I'm going to be controlling the slides, but my colleague, Arielle Miliambro, will talk a little bit about HIPAA.
Good afternoon. So in order to access or use any of the practice data for the arrangements that Dan has discussed, the practice first has to navigate HIPAA and the protections that it affords to the PHI at issue. HIPAA is directly applicable to covered entities such as healthcare providers and their business associates. And with that, with the assumption that HIPAA applies to a physician's data, we first ask, what is PHI? PHI is protected health information that means and includes any individually identifiable health information that's collected by or on behalf of a covered entity, so the healthcare provider, from an individual that relates to the individual's physical or mental health condition or the treatment or payment therefore, and can be used to identify that individual. So what does that mean? That's a long-winded way of saying that essentially all patient data collected by the healthcare provider or on behalf of the healthcare provider, including the patient's demographic information, is going to be considered PHI. When can PHI be used? The answer would be that it can only be used with a patient's authorization, except where permitted by HIPAA. So the permissible uses relate to treatment, payment, and healthcare operations. And if a practice is accessing or using or disclosing data for one of those purposes, a patient's authorization would not be required. Healthcare operations is where we focus for purposes of these data contracts, first of all, because it's very broadly defined and includes things like quality assessment and improvement, outcomes evaluation, population-based activities relating to improving health or reducing healthcare costs, and the general business management of the covered entity. It also specifically includes the activity of creating de-identified health information, which a covered entity or its business associate is permitted to do, even if the covered entity doesn't intend to use the de-identified data itself. So if it intends to sell that de-identified data, that would not be a restriction on the covered entity either de-identifying the data or directing its business associate to do so. So we'll discuss how to de-identify data and what that means for the data set, but briefly before we do, it's important to note that obtaining a patient's consent to de-identify their information is not necessary. Again, authorization would only be required if there's no other permissible purpose for the use or disclosure of PHI. But when a practice is de-identifying data, it's doing so pursuant to the healthcare operations exception. So authorization is not required. Notwithstanding, we have seen certain practices choose to issue opt-out notices to their patients, and those notices would indicate that the practice may aggregate de-identified data and that no PHI will be used, but the patient may nevertheless opt out of having his or her information included in that de-identified data set by taking some affirmative steps, such as emailing a designated address and requesting the opt-out. But again, offering that opportunity is not mandatory, but it's something that some more conservative practices have sought to provide their patients. Next slide, Dan. So de-identification can be accomplished in two ways. The first is to engage a statistician to make a determination that the risk of re-identification is sufficiently low, or by removing a number of identifiers based on a pseudo safe harbor of HIPAA. And pursuant to that safe harbor, information is only properly de-identified if every required field indicated in the safe harbor is removed. So those fields include the patient's name, the patient's address, all elements of date other than the year, telephone numbers, email addresses, social security numbers, and so on and so forth. Once all of these factors are removed, the data meets de-identification specifications, and at that point, it is not considered individually identifiable. So it is no longer PHI protected by HIPAA. Based on that, the restrictions on data, such as the prohibition on sale of protected health information, won't apply to a data set that has been de-identified. So once the data set is properly de-identified, either using a statistician or through the safe harbor, the practice can then sell that set without violating HIPAA. And with that, I will pass it off to John.
there are a variety of regulatory concerns whenever we engage in a practice of selling anything to a third party that is in a position to make referrals and remuneration coming back the other way. We have federal anti-kickback statute, which is the major concern for these types of transactions where a provider such as a physician or pharmacy is selling data, and that data is being sold to, for example, an entity like a drug manufacturer, where either the physician is in a position to order that manufacturer's drug, or in many cases to a pharmacy that is in a position to dispense an expensive brand drug in lieu of switching that to a less expensive generic drug, which is a very common practice. So how do we assure that we are not getting in trouble by selling data? Well, the anti-kickback statute has a variety of safe harbors, and the safe harbor that is most often used is what's called the personal services and management contract safe harbor. And the touchstone of that safe harbor is that the compensation for the data being sold is fair market value and commercially reasonable. Fair market value, when we're talking about data, as Dan mentioned earlier, can vary widely. In many ways, the value of data is in the eye of the beholder. Manufacturers of drugs and other types of suppliers, DME companies, etc., may prize this data because it provides them market analysis of their market share, of who's ordering their product, how often their product is actually reimbursed, whether insurance companies are approving through prior authorization the use of their product. Just a myriad of reasons why that data is valued. And typically the best way to assure fair market value is getting an independent third-party valuation from a recognized valuation company. And there are a number of well-respected national valuation companies that are actually even used by the Department of Justice and the Office of the Inspector General. So you want to get a third-party valuation. The other aspect of the safe harbor is commercial reasonableness. And again, Dan touched on this earlier. What does commercial reasonableness mean? And that is very often kind of a slippery concept for people to understand. But commercial reasonableness in the context of the safe harbor would a rational business person pay for the data even without the potential referrals? So in the context of a drug company, if they're already getting the data from another source, perhaps their own sales force, there's not a commercial reasonable purpose to pay somebody for duplicative data. So that wouldn't be considered reasonable. So we have to also look at commercial reasonableness. And kind of the third prong that very often comes into play in the safe harbor is that the compensation for the data is not based on the volume or value of referrals. Now, that too is a very, very slippery concept and difficult to manage in the context of data, because obviously the more data that's involved, the more valuable it is. So how is this addressed? Again, the concept here is that the payment for data is not done in a manner that's going to influence the independent clinical judgment of either the physician, the prescriber, or the pharmacy. So an example of a prohibited conduct where it would likely violate anti-kickback is where a drug company pays a pharmacy for information on a prescription, but only on those prescriptions for their drugs. We've seen contracts where the manufacturer will pay $50 each time a pharmacy reports on their drug. The problem with that is that the pharmacy is now having an incentive to make sure that that brand drug, which may be much more expensive than a generic version of the drug, is actually dispensed. These types of contracts are very complex, and to analyze them from a regulatory standpoint, one needs to really drill down. We have seen, for example, contracts where part of the process is that to keep the generic drug being dispensed and therefore being able to send the data to the manufacturer and get paid, the pharmacy will be incentivized to reach back out to physicians or the prescribers and change the prescription to write dispense as written so that the insurance company will cover that drug. So these are all issues that usurp the independent clinical judgment of a licensee. So one needs to be very careful. And obviously the same thing holds true for physicians. If physicians are being paid for particular information and they only receive that compensation when ordering that manufacturer or that supplier's product, that too can lead to an anti-kickback violation. There are a variety of other regulatory concerns when looking at selling information. As Arielle spoke about HIPAA, if you clearly de-identify and de-identify correctly, you should be in a good position. However, the Office of Civil Rights is charged with the enforcement of HIPAA, and where there has been inappropriate or suboptimal de-identification of data that's then circulated, the Office of Civil Rights can come in and exercise their enforcement discretion on providers or covered entities or business associates that have violated HIPAA. We also have some concerns from state licensing authorities who look at confidentiality of medical information. Boards of pharmacy, boards of medicine have taken enforcement action where clinical information, individually identified clinical information, has been violated. And there's also a variety of other state agencies. One thing that we talk a lot about HIPAA, but there are many other state agencies that also are concerned with individual data. There are, outside of the context of healthcare data, but there are additional confidentiality and privacy laws that do apply. So very often you see in a medical practice, there's certain data that's collected, such as credit card information, driver's licenses, things along those lines, that are regulated by state agencies that have stricter enforcement than just merely HIPAA. Next slide, please. So I've touched upon, the anti-kickback statute, and that violation of these laws, like anti-kickback, in and of themselves are problematic, but they can also result in false claims acts, enforcement. As mentioned, licensees can be disciplined by their state boards. We've seen boards of pharmacy and boards of medicine increasingly taking action against inappropriate disclosure to protect individuals when their information has been inappropriately disclosed. So we want to make sure, particularly when there is pecuniary gain for the seller of the data, that we really keep a very tight reins on the information that's being disclosed and the manner in which it is disclosed. Some of our commercial insurance contracts, particularly PBM contracts in the pharmacy space, but just commercial health insurers, have additional terms in their provider contracts that limit the disclosure of information. Another area on that's concerning is your EMR contracts. Are there restrictions on what you can do with the data? But more importantly, are there restrictions in those contracts on what your EMR provider can do with the data? Again, understanding that we need to make sure that the EMR contract clearly delineates who has control over the data and who owns the contract. And then finally, in this environment where people are, the public in general, are very concerned with privacy issues, you also want to be very careful, A, that you're not not violating any law or any licensing authority, but also to be sensitive to patient complaints that can affect your business. People, even though information is de-identified, individual patients may be upset that you've sold their data, even though it doesn't identify them directly. So that is again another concern, that when you're going to sell data, to be very cognizant of the sensitivity of the data and possibly the concerns of patients. Next slide. And I think at this point we are opening it up to questions.
Thank you so much, John. So our first question we received is, regarding PHI, is the medical record number a PHI element? If not, can a combination of date and medical record number be considered non-PHI? Arielle, I think this would be great for you.
So with respect to the safe harbor method of de-identification, the medical record number is a specific element that does need to be removed in order to properly de-identify a data set, as is the date. The only element of date that would be permissible, pursuant again to the safe harbor, would be the year. So if there's a particular piece of data that a practice is trying to extract, it would be challenging to do so with either of those identifiers, unless a statistician made the determination that the set was properly de-identified and there was a low risk of re-identification. Now, certain data requests that we've seen sometimes relate to the amount of a particular drug that is dispensed in a given month. And so obviously you can't make that disclosure without disclosing the date. So it's not as simple to de-identify when those are the factors that are required, but there are ways to make that data available without it being considered individually identifiable, such as aggregating that data prior to disclosure.
Thank you, Arielle. All right. I believe so far that's our only question. So I'll start it with the conclusion. So thank you all for joining today's webinar. If you were not able to like answer any other questions you may have or anything, please give us a call and we'd be happy to answer them. And as I stated earlier, the recording is will be available on demand later on. And please give us a call regarding any legal concerns you have regarding patient data. Have a fantastic day, everyone. Thank you.